Oh, sorry, forgot to start the recording. Maybe I should start over for the recording. Sorry, folks. Oh God. So we got here today, Dr. Sensemaker. She's a rheumatologist at Leeds Teaching Hospital, NHS Trust, and she's bringing us a QI case study, which is around supporting patients taking oral corticosteroids. It's a very hard word to say. Yes, I practice. And especially around systematizing patient feedback using a tool called Sensemaker. Which brings us to Ali Snowden, who's a master in the anthropology of social development and transformation, which is specialism in medical anthropology. She's currently leading the Knaffen Center Health Program, supporting members using Sensemaker. And since this was a very requested tool from our community here, we thought that was the perfect opportunity to not only bring you something about the tool, but a real life example. And with you, Sarah and Ellie.
Thank you so much for that lovely introduction. I'm now going to share my screen. So here we go. And let's put this on slideshow. There we go. Thank you for the intro. And so this is not about our QI project itself, because that is still in the planning and still in effect, but this is about how we're involving patients in designing this QI project. And this is really a work in progress. So we're in the middle of everything here, and we would love to hear your thoughts and your feedback as to where we might go with this and any advice you might have for us. So I'm going to start with a context. So started with a disease which we see in rheumatology fairly commonly, and it is called polymyalgia rheumatica, which is a bit of a mouthful, but it's basically an autoimmune disease that affects older people, and it causes inflammation around the outsides of the shoulders and around the hips, and it makes it very hard for patients to move, and they can become quite unwell with it. And it's treated with corticosteroids, or sometimes we say steroids for short. But so these work really well to treat the inflammation. It's absolutely fantastic, but their side effects are manifold. So they produce a multitude of side effects in terms of physical health and mental health. In terms of the mental health side effects, anxiety, sleeplessness, so you don't sleep at night, wake in the night, and of course because you're anxious you worry about things, and over time, because steroids make you hungry and they make you put on fat in places you don't want to be fat, you can put on weight, and that can lead to all sorts of other health problems. So there's a very, very long list of steroid side effects which these patients have to contend with, because a polymyalgia doesn't go away by itself in the short term. These steroids need to be taken for in the long term, so of the order of years. So currently in the UK, PMR is generally diagnosed in primary care by GPs, and it may be referred to us in secondary care and rheumatology for various reasons. So if there's doubt over the diagnosis, or if patients are having a lot of flares, or if it's hard for them to get off steroids, or if they're having steroid side effects. But the patients that we tend to see on our rheumatology clinic are perhaps a bit selected. So there are probably some inequalities in how this is diagnosed. It may be diagnosed more and more affluent areas, and also referrals. So you're more likely to be referred if you're like a pushy middle class person compared to someone from a more deprived area. The Getting It Right First Time report for rheumatology, produced by NHS England, really put a call out that better clinical pathways are needed for this disease. We need to figure out how we support primary care better in what they do, and patient involvement is required in design of these better clinical pathways. And in the meantime, from NHS England, we are currently going through the Outpatient Recovery and Transformation Initiative, and we're encouraged to use patient-initiated follow-up as much as we can. But if that's to work, then patients need to be educated. And there isn't really a kind of standardized education for this patient group, or indeed in general for patients who take steroids for any medical condition. And we use steroids quite a lot in rheumatology for all sorts of our inflammatory diseases. So we did some preliminary work, which we got a little bit of money from Wellcome Trust via the University of Leeds. We ran a project which was called PMR Voices 2021. And one of the things that came out of that is that, of course, these patients were talking to us during the winter of 2021, so pandemic lockdown, and they just said they just felt that they were left to get on with it by themselves. The disease generally seemed to be ignored by doctors and by the community and just not heard of. But even once they did have a diagnosis, they were often sort of left trying to figure out what to do all by themselves. And they said that what they felt they really needed was not necessarily like more and more drugs, which is what they many of them reported they tended to get from us doctors, but of a more holistic approach. And what they felt would be potentially achievable, and a direction that they recommended might go in, was to figure out how to support patients to manage their steroid side effects. And of course, this would be also relevant for many of our other rheumatology patients who also get treated with steroids. And in the meantime, our department in Leeds, we seek feedback from patients on a regular basis, and on the clinical nurse specialist on our improvement team told us that really the consistent themes coming back from patients is access and communication. So how do they get access to our service, and then the quality of the communication they get when they do manage to access us. So this felt like a bit of a theme and something we wanted to make into an improvement project. So what we have at the moment is we have a rheumatology clinic, and we have an inquiry line, which is a sort of answer phone service where patients phone up, they leave a message, we get back to them, and it may be an administrator or a nurse specialist that takes that call and talks to that patient and decides what they're going to do. But patients are only offered appointments at quite long intervals, even if they get referred to rheumatology. So we have limited capacity. So maybe they might get 15 minutes follow-up appointment every 3 months if they're lucky, which isn't very much. There seems to be quite a mismatch of our capacity versus demand from our patient groups. So this is a one-year project that we so I'm supervising 2 medical students who are on this call, Hussein and Funmi. And what we want to do is to design a QI project to select and test out and evaluate one or more small improvements that might make things a bit better for these patients, and to take this pilot and evaluate PDSA cycle type approach, but instead of deciding for ourselves what was going to help patients, to really involve patients as much as we can in designing what this intervention might look like. So what we did was convened a focus group with patient research partners, and there are many different types of side effects that steroids can give, and patients said, well, it is important that we know what they are, so we can tell you that we're getting them. We don't always get told what these steroid side effects are when we get prescribed them, but it depends what sort of side effect it is. So whether it's a visible or an invisible side effect, whether it's something that you notice or something that's going on inside you that you may not be aware of. Some of them get better with time, some of them get worse with time, and it's important to know about that. And patients have to make a decision for themselves about whether they just put up with them, they cope with them, or whether they need to take action in their life to manage and mitigate. So that might be diet or physical activity, or kind of taking medications in a different way, or seeking medical advice. So there's quite a lot of complex decisions and thought processes that patients have to go through, and we don't always teach them how to do that very well. So we spoke with a psychologist working at University of Leeds, Hilary Becker, and she recommended we look at Levinthal's common sense model of illness representations. And really what this says is that when something happens, a threat to your health, then you develop a cognitive representation. So you think through, like, what is it, what caused it, what are the timelines, how can I control it, and what's the consequence. There's also the emotional side as well. And then depending on that cognitive side effect or the cognitive representation or the emotional representation, you then have coping strategies, and then you reflect on how that went, what happened, was it a good outcome or a bad outcome? And then you might have this feedback loop where you learn over time more about the illness, more about how to cope with it. And it's for chronic diseases, this feedback loop is kind of constantly cycling, it's constantly going round and round. So it's not like a linear process or a kind of journey through the illness. It's happening kind of all together and all at once. And the emotional and the cognitive side are really, really intertwined. So that was kind of the theoretical background that we used to kind of think through some of the things for this project. And so in our clinic, we just have a limited number of patients, and not all of those patients want or can engage. So what we wanted to do, because this is side effects, and side effects are so diverse, we wanted to capture the full diversity and wanted to involve patients at scale. So we worked with the Cynefin Centre and Ellie to design a Sensemaker survey. We had 2 patient partners who worked with us quite closely on this, and we disseminated that out via online communities. As expected for a side effects project, so drugs the benefits of drugs are hopefully relatively consistent, but the side effects are so variable between patients that you do need that huge number of responses to get that full diversity of all the different side effects, but then all the different situations that patients may find themselves in. And so we had quite a few responses from all over the world, and that was lovely. And then we had some sessions with the improvement team and with our patient partners to do some sense making and try and make some sense out of what we were getting back from this survey. So I'm now going to hand over to Ellie and stop sharing my screen because she has her own slides. And she's just going to talk through some of these methods and in general how it works, and then a little bit about how we did this in this case.
Cool, thank you so much, Sarah. Hi, everyone. Okay, so I think I can see a few familiar faces here. So I know that some of you have either used Sensemaker before or are very, very familiar with it. But what I'll do for those of you who aren't is I'm just going to share just very high level what Sensemaker is all about. And then I'll show you some examples of the types of questions that we ask using Sarah's project as a specific example. And I'll talk a little bit about how we get to those questions and then what we do with them and the data that we collect afterwards. So essentially, Sensemaker is designed to be a mixed methods research tool that allows us to do narrative capture, but at scale. And it does this through a combination of eliciting micro observations or narratives that we ask people from multiple perspectives to share from their day-to-day lived experience, and then combining these narratives with a quantitative framework through a process that we describe as self-signification, and I'll give you a visual on that in a moment. But crucially, what we're doing is we're asking the person who shares their story to themselves indicate a higher level of meaning or importance to their own experience. So in a sense, what we're trying to do through the tool and the ecosystem of methods that surround it is as much as possible really to widen out or distribute that research process. So this might look like asking children to be ethnographers in various communities and interview people in their villages, in their towns of different generations. It also can look like asking people various kind of stakeholder levels to look at the stories and the data that's coming back to make sense of it and to define that kind of crucial direction of travel or that insight to action piece where we want to go with this next. So I'm just going to share my screen for one moment. Okay. So as I said, with Sensemaker, then central to this is the collection of what we would call a micro narrative or an observation of an event or something that's happened in a context that somebody is very familiar with. So the first thing that we do when we ask someone to take part in a Sensemaker survey, which they can do either through an app or through a URL, like a kind of traditional type survey, is we ask them to share this story. And what I'm showing with you here on the screen is the story prompt that we use on Sarah's specific project. So we're asking somebody to imagine that they've just been started on, imagine that they're speaking with someone who's just been started on steroid treatment. Thinking about your own experience, is there one incident or event that happened that you could share with them that they might find helpful? And there's various ways that we can design this story prompt depending on the objectives for the specific piece that we're working on, of course. But what we really want to do is we want to keep this prompt nice and open, hopefully with no hypothesis behind the frame, so that we're not kind of limiting the parameters of possibility in terms of what we can say. So we want to keep this really open right from the outset. And some of the premise behind this as well is to capture those kind of unseen stories. So the stories about someone's side effect experiences or about their condition that they're living with, that in the 10 minutes you have in, say, a GP encounter, you might not necessarily be capturing or understanding in their full complexity. So on this particular project, we had 3 different collector sites. We collected from people with lived experience, so from patients, and this is the prompt that we used here. We also collected from healthcare professionals on a separate site, and then from families and or carers of those with lived experience on a separate site still. So as you can see, we've used a fairly similar prompt, but for the healthcare professionals, we asked them to share one event or anecdote about a particular case that we might find helpful in considering how in our clinical service we can better support our patients who take steroids. So for the end user, for the participants, they're invited to type their story, they can do an audio capture, they can really share as much or as little as they like, and we tend to get quite a diversity here. As you can well imagine, healthcare professionals is a lot shorter stories from those with lived experience. And once they've shared their story, their observation, we then ask the participants to give this story a title or some keywords or sometimes some hashtags. And the purpose behind this is we want them to give that layer of codification or abstraction of meaning themselves. So in my old job in public policy research, when I did a lot of qualitative interviews, I had my predefined themes of interest, my Excel sheet, and I would have to fit quotes into these various cells. And that just didn't quite fit with a lot of the experiences I was hearing. So with this, what we want to do is to mimic that process, but crucially, we're giving that observer, that storyteller themselves, the power to define at that level in this moment. So there's a couple of different ways that we can use those story prompts. I'm sharing with you another couple here. A piece that we've been doing with the Royal College of Nursing throughout the pandemic, where we were really asking nurses to use Sensemaker as a journal and share in an ongoing way, the week by week or month by month. Really, really open, reflective prompt here. And then this one here, hopefully you can read this text, more specific. We were working with a multidisciplinary team across the health and social care. And we were looking for kind of different definitions around this concept of delayed discharge. And in this case, we were pulsing out different case studies to various roles across this kind of broad system with the view that we would then bring this information back to encourage some learning across silos and some communication across silos. So once a participant has shared their story, we're then linking this into the quantitative framework that I mentioned earlier. So we do this by asking the respondents to think specifically about that story they've just shared, as opposed to their overall experience, and to consider their story in position to a number of concepts or modulators of experience that we map out in various shapes as the survey progresses. So just to give a couple of examples of this, at the high level, we might have this triangle shape here that we call a triad. And we're doing on the collector site that they're taking part in is we're asking them to say, where does my story sit between these three concepts or ideas? So this marker that you can see in the middle, they'll drag it between if they felt in their example events were affected by just governance alone, they would put their marker in this top corner in the extreme. If it was a combination of all three, they'd go in the middle. And the idea behind this is we want to increase the cognitive load a little bit on the response in comparison to a traditional quantitative survey, with that deep context of the narrative they've just shared in mind. And it's very much with the view that, the story I share this morning might elicit a very different placement on this shape to the story I share this afternoon, and that's okay. As much as possible, we want to kind of keep the research process alive in the signification process. So this is the triangle shape, the triad, and we also have sliding scales where we're looking at maybe tensions, in this case between, say, risk and certainty. And then we have multiple choice questions that can be on things like demographics or how people feel about the story, which we can then overlay as filters when we come to look at the data from the output on these particular shapes. And I'll show you what that looks like in a moment. So just drawing on some of the triads that we designed in this particular piece, and bringing it back to Sarah's points earlier around the common sense model. What we did here is we built components of that into a particular triad. And I'm showing you here on this screen what this looked like for those three different cohorts that we did a collection with. So this one here we have for the patient. So in the story I shared, I was understanding what effects steroids could have on me, coping with the effects of steroids, learning from experience what worked best for me. And as Sarah said earlier, in recognition that this is not a linear process with a chronic disease, you're in a continuous state of flux between these 3 points. Again, it's that balance or tension rather than mutually exclusively picking one over the other. So you've got the patient output here. And then in the middle, we have the wording that we used for healthcare professionals. So you can see that we have the same high-level concepts, but we've just changed the language slightly so it's more applicable for that audience. And then on the right-hand side, we have the version that we worded for family members or carers, for those with lived experience. And when it comes to designing these signifiers, this particular one was designed based on theory. Quite often, if we're doing a co-design process, what we might do is we might do something like a story sharing circle where we're asking those with lived experience to share, the extreme positive or negative stories that they have in their experience as a whole. And from that, we might be asking them collectively as a group to take some core concepts and to work together to design these triads in a more collaborative way. And actually, Sarah might speak a bit more to this, but we took a slightly kind of combination approach to this in this short pilot, albeit with the small team that we had, which was pretty interesting. So just to give you a sense of some of the other things that we were looking at here, we wanted to understand where people felt trustworthy information came from. So my experience, my embodied expertise, healthcare professionals, the more official medical websites, other people, peer-to-peer knowledge flow, online communities, expertise by experience, and so on and so forth. And then looking at this sense of, you know, what kind of side effects of steroids are seen and unseen, and a temporality lens, I think, to this one too. And then specifically thinking about improvement, we were asking people towards the end to think what might have made things better in the context, again, of their stories. So focusing here on communication, accessibility, and actually just the realities of life circumstances. So I'll just show you a little bit about what the output from that can look like. And then I'm going to show you how we did some analysis with our research group on this preliminary analysis. So just coming back to this signifier that we showed you around the common sense model. This is the kind of bird's eye view of the data set solely from the patient cohort that we collected from. You can see that each of these dots represents a person's story, person's narrative, as opposed to a person as a whole. And what we can do with this is we can look to things like demographics to see if there's any interesting differences in patterns that we observe on this. And we can also draw around the patterns of interest, and immediately that will bring up the stories to give us a little bit more of that deep context to help us explain what those patterns are all about from the eyes of those who shared with us. Okay, yeah, and I'll just show you a couple of other patterns from this piece, again at that bird's eye view. This time we're splitting the data set between patients on the left on this trustworthy information piece. You can see it's fairly scattered, but perhaps slightly more leaning towards the top and the bottom right-hand corners as opposed to healthcare professionals. There's a bit of a gap there. And then on the right, we have the output for healthcare professionals. And we can see almost an opposing pattern there. So this kind of, it can be really, really interesting when we get to perhaps, you know, workshopping some of these results, especially if we're working with a really large group in a workshop setting. We can really maximize that role diversity to work potentially quite creatively with difference. And quite often just looking at this kind of bird's eye view of difference with the patterns can encourage some conversations to happen in maybe slightly different ways than they have before. So I'm just going to pause my screen share for there. And before I get the Miro board up, Sarah, is there anything else that you wanted to add to that at this stage?
No, I think this is great. Thank you.
Cool. Okay. So I'll just quickly then show you then how we worked with some of this data in order to take a more collaborative approach to the analysis. Yeah, so in this particular instance, because we were working only in an online space, we made use of Miro, the platform. And I actually shared my screen and I acted as a scribe, and I asked people to have a look at some of the patterns and the stories. And then you can see on these little post-it notes, we basically got people's interpretations of the results. So the way that we did this, because when we have a Sensemaker data set, you know, when we've got stories into the hundreds or even thousands, because it's very much about looking at relationships between things, there's a huge amount that you can do. And quite often it's phoning it down to say, what are the 2 or 3 specific things that we want to focus on with this particular group or with that particular group? And there's various kind of different configurations of workshopping that you can do there depending on who you need to be in the room. And in this particular instance, once we'd had a look at the overall data, we actually asked those with lived experience and the research team to sort of suggest some of the emerging questions that they were getting from looking at the overall data set. So what we're looking at on this particular screen is Margaret's suggestion. She wanted to look at how much of your understanding of the effects of steroids resulted from the information given at diagnosis. So what we did here is we isolated a segment of the data set, actually looking to corroborate between 2 different triad patterns. So we took this corner, this extreme corner where people said things could have been improved with better accessibility of care and information. And we mapped that onto this triad around the common sense model. And from that, we then looked at some stories from these three extreme corners. And we asked the people that were in this workshop that we held online to read the stories and to extrapolate some of the key themes that they were finding, as well as kind of layering on their own experiences that were coming to mind as they were reading these stories shared by others. And what we started to do is we were writing these out in blue. And if there was a key kind of overarching theme emerging from some of these other observations that were coming through, we'd give it a bit of a title. So something here that really came through was, what is the role of guidelines? For example, when we're looking at stories where people are really in this kind of maybe early on understanding phase in terms of what effects steroids might have on them. So I'll just maybe let you read that story just so you can get a sense of the kind of data that we get through from this. Is that an okay size for people? Brilliant. And just a note on this as well, with this particular project, we built in a variable consent. So along with the overall consent to take part, we gave people the opportunity to say, yes, I'm happy for my story to be shared word for word, versus no, I'm not. So that's why you're seeing this blacked out grey box below. Okay. So as I said, we tend to find that we get quite a diversity of stories through from this. And again, we can split down to demographics to see if there's any kind of interesting differences in the way that people are making sense of things. And quite often, you know, especially when we're working maybe with experts, when the stories come through, there can be some interesting noticings of a surprise. You know, why did a person signify their story in that way? And this kind of need to probe a little bit deeper. And this is where this becomes much more than a kind of extractive research collection tool. It's about kind of asking these questions to a wider audience and taking it a little bit wider. So I'll just pause there because this is pretty much where we've got up to at the moment, this kind of notion of looking through the stories, identifying themes. And I'm going to hand back to Sarah and to share a little bit more on that before I think we'll go into some breakout rooms to hear your thoughts. Thank you. I think you're on mute, Sarah.
Oh yes, sorry. I was trying to work Zoom. We usually use Teams, and it turns out that I'm not as good at Zoom as I thought. So we've done Ellie, and now I'm just going to briefly talk about where we are right now, and then we'll maybe go into either one big discussion room if we don't have many people, or we could split into two breakout rooms. And I'm not sure how many participants are on the call at the moment, so I'll just leave that to Joriam to decide what we do. But some of the things that started to come out from the discussions with our experts by experience and our clinical nurse specialist, and we also have the liaison psychiatrist on our improvement team as well, is that this is real fundamental cornerstone of understanding. So this, if you don't have the understanding as a patient, and if you're on that triad of patients are not marking themselves anywhere near the understanding corner, then often things get increasingly chaotic and difficult. So there's this huge role for education, and education our experts by experience told us that it's not just a one-off, you get a leaflet and off you go. In fact, no one really likes leaflets. It's a kind of ongoing process over time, and you take on new information at the right time for you, and that's different for different people. What we also came out from some of just the quantitative data that came out from the survey is that we asked people to select from a tick list of which side effects of steroids they're talking about in their narrative, and the commonest one perhaps not by far, but certainly the commonest one, both for the patients and for healthcare professionals, was mood disturbance. So the sort of psychological impact of the steroids, the condition, everything, was the commonest thing that came into these stories, which really, I think, if people were choosing to talk about things where their psychological health is impacted as well, I think that's really starting to tell us something about the importance of acknowledging the psychological impact of steroids and the diseases, as well as the more physical doctory things that we often focus on a little bit more in kind of doctor-led improvement projects. And what was also interesting is that if you drill down into that, because people are allowed to tick more than one, that sometimes it was just mood disturbance by itself, but quite often it was mood disturbance plus other physical side effects. So mood disturbance plus diabetes, mood disturbance plus weight gain, mood disturbance plus. So it's this real intertwined nature, and the narratives that came through really didn't draw a clear dividing line between those two. And then reflecting back with our lived experience experts about, so one of them has a background in teaching, and she used to teach secondary school students. And one thing that she said during our session is that anxious students don't learn. So she was thinking back to her experiences as a school teacher, but this is very applicable to anybody with a health condition, because you become a student, if you like, of your own experience, but then also of the knowledge that's out there about your health condition, about the treatment. But if you're feeling very, very anxious, then you can't learn because you're so busy worrying. And the problem is that these medications particularly tend to magnify any anxiety you may already be experiencing, just because of their actions on the brain. So we need to pay particular attention in this context to those psychological side effects and what that means. And then the other thing that came through from this discussion, having read a lot of these stories, is the real value of human connections. So again, a leaflet is kind of nice, but what the patients are really valuing is that human connection, with the healthcare professional. So talking to someone about what you're worried about, or maybe what you need to be worried about if you're not worried about it yet, and what you can do about it. So that talking and that interpersonal relational aspect is so important, but then also the value of connecting with other people with similar experiences. So we were surprised, many of our patient partner said she was quite surprised that in the survey a lot of responses said, I think many people have quite similar experiences to me. And she said, but we're all different. How can this be? But I think that need to find connection, that need to find correspondence with other people and share experiences and find similarities is particularly important. And it, again, in the isolation that we've had of the COVID pandemic for older people, and this age group is predominantly an older age group, this is super important. And so that was perhaps, so where we are at the moment in thinking about where we're going to go to designing our intervention, it seems to be very much something that needs to be human-centered, maybe some kind of group element so that patients can find that commonality with each other, and something really centered around education, but in the very broadest sense, and acknowledging sort of mental health impacts as well. So so this is where we wanted to do breakouts, but we don't need to do breakouts if there are not so many people on the call. So Jorian, what should we do? Should we split into two, or should we just have a kind of panel Q&A and people can ask questions to Ellie or myself to clarify or to share similar experiences?
We currently have 32 people on the call. Based on that little conversation we had just before the call, I'm imagining that this is going to be more useful if it's just a single room organized Q&A. I see everybody nodding. Excellent.
Yeah.
So folks, if you come to Q calls before, you'll be used to this. We organize those types of Q&As using the raise hand button, which is under reactions on your Zoom menu. I already captured one question from Linda and two questions from Mike. So these are the people I'm going to invite to first open your mics and ask you questions. But please, everybody, just use the raise hand function. We have 10 minutes for that. Am I correct, Sarah?
Yeah.
Cool. So we have time for a couple of questions, and then we'll carry on, and there will be another moment when I'm going to open the mic again. Okay.
Well, hey, so I'll go first. I'll go with the second question, and only because, so I spent a decent amount of time in a healthcare facility working with doctors and providers. And a challenge we ran into a lot were what we call data deniers. So as we shared patient experience, employee experience data with a lot of the doctors and providers there, we get a hard pushback saying, that's not what happens, that's not what we did. So the challenge was, these are great methodologies, and I really enjoy them, I know this. I'm wondering if you ran into that inside your practice and how this in some way supported shifting conversations or changing conversations around the most staunchest providers who consistently feel that the patient experience or how they experience the interaction is not true, or it's not how things actually happened.
So I guess that's something that, because we're just in the early stages of our project and we have yet to kind of roll out or scale in any way, we're just working with our improvement team at the moment. We're in the lovely position at the moment where the improvement team is all very much brought into the problem. We all believe it's a problem. We all really want to listen to the patient experience. So I think what I have found in other improvement projects is that different stakeholders, if you like, different metrics will speak to them. So if their concerns are the backlog or the difficulties, so we have an inquiry line, it's massively overwhelmed. We have lots of people ringing up for things that perhaps they could have taken another route, maybe education could have forestalled. So if you start to see an impact on like workload, on the workflow through the department, then that is really, really important for all of us on the provider level. Actually, we're very lucky in Leeds in that our lead clinician is very supportive of this project. So we've already discussed it with him, and he's just absolutely, this is fantastic. And so he's very, so he's totally bought into the idea already. And that's really key, is getting the person with the power to say, yes, do this on your side. And then there will always be people who disagree. And equally, we have also found there are always people who say, we knew this already. I knew this is not new. We're already doing what we can. And, it's inevitable that, patients always say this. Well, yes, they always say this, but what have you done about it? So I think it's just recognizing that there will always be people who, if it wasn't their idea, they're not really interested, but they do like the effects. So if the service does genuinely improve and there are measurable impacts on things which matter to the people that have the power to give the resource to make it happen, then I think I kind of count that as a win. And it is normal to have people who do not necessarily understand the power of this approach, because just of the model and the training that providers have. Yeah.
Grant, okay, so Linda had asked a question right at the beginning, so I think I'm going to give you priority. You can go, Linda. After that, we have Anita, then Rob. You folks are not using the function. This is hard, but we're going to figure it out.
Sorry, my apologies. I threw that off. Thank you so much. It's been wonderful to be part of this. We use Sensemaker in healthcare in Northern Ireland, health and social care in Northern Ireland, in a programme called 10,000 More Voices. But I think what really bounced off me, and I know, Ellie, you've probably answered the question, was the fact that you used the same questions for relatives, carers, and for health professionals, and for the lived experience as well. That's something we don't do here in Northern Ireland, because there's that sense that the staff have a different story to tell. So I just wondered, is that something you would always advise to do? I'm thinking maybe directing this at Ellie or Sarah, because it did seem to come across as really beneficial when you showed the analysis there, because at the minute what we do in Northern Ireland can be two quite separate things. So we have a piece on lived experience for social workers at the minute, and then we're trying to sort of push the idea of, well, what's it like to be a social worker? And they're kind of coming back with two different concepts and things. So how did you design that? How did you kind of try and tie those course concepts together, was my question.
I think it's a really great question. And, on the health projects that I do with Sensemaker, we don't always take that approach. And actually on a mental health related project the other day, an expert by experience said, actually, I think I would want to ask completely different questions from families and carers, because they have a very distinct experience in this. and actually this isn't going to encapsulate it. I think sort of looping back to the first question, there can be a lot of value in taking people through that same process from their different roles and then coming back together to show that difference or that similarity. Perhaps especially if you've got some of those people who, as Mike was saying, you maybe don't want to listen to the patient experience, because when you've got a pattern there, it's a lot harder to disagree with than a story. And in some senses, you know, quite often when I work with nurses using this tool, they love it because it's kind of making anecdotal the things that they see day to day and they want to change. It's making that evidence in some way, or has the potential to. Yeah, I'm also really intrigued to hear Sarah's thoughts on that piece too, from a more kind of clinical perspective.
I think, well, just as a doctor, you do kind of get a little bit trammeled into your day-to-day workload, and that you stop seeing things and you forget about, and you don't necessarily see things the way that patients see them. And then just seeing that contrast between the patterns visually, between the healthcare, you know, in terms of where patients get their where the trusted information came from in the story. So it was totally different. And the healthcare professionals thought the patients got their trusted information from the healthcare professionals and, you know, from their own experience, didn't really acknowledge other individuals, because we have a very kind of, the way that we are taught medicine is very much kind of the doctor-patient relationship at the center of everything, and then that's all confidential, and then everything else is kind of blacked out. But actually, of course, patients live their lives in a social network, and the doctors are not very important in that at all. And what is important is their family, their friends, the people that they have connections with in their actual lives, and what their relationship with their doctor is only a very sort of black and muted and less rich version of real relationships. And I think seeing that as a doctor, you start to realize that actually you're perhaps a little bit less important than you thought you were, and to start to understand why it is that sometimes some of the challenges and barriers which seem insurmountable, kind of recognizing where some of them come from, and recognizing that how patients may see things differently, and also realizing that there may not be the easy solutions which you think as a doctor ought to work. You know, you sort of have this kind of sense that you are very powerful and you can just like give them a leaflet and then they'll know everything, and that is just not true.
Yeah. Thank you. I think it's an approach I'm going to try taking. We're developing one around shared decision making. It'll be interesting what people think that truly means. So thank you very much for answering my question.
Folks, we have two invisible raised hands, one from Anita and one from Rob, but just a point in time, there's only 2 minutes left. So the answers are really deep. Oh my God, 10 minutes, too fast. Anita, do you want to ask your question?
Yeah, I just wanted to ask how you're going to continue to involve patients in your work, and how involved are they within your QI process? But also, when you present back in future times, are you going to involve the patients to come in and share their stories as well?
Oh, patient involvement. So this originally came out of this patient involvement project, PMR Voices, and then a subset of those took part in this, this follow-on thing about steroids, and they were there in that focus group and helping us design the survey. And then our two kind of patient partners, if you like, who have been very much sort of co-leading this process and helped us design the survey right from the start. So they've been very much involved at every meeting. And the only reason I didn't invite them today is that I don't want to exhaust them, because it's been quite an intensive process. and I thought I would want to give them the preparation and the support that they would needed to engage in this kind of Zoom. But absolutely. So we have so far written abstract for a rheumatology conference about our experiences with this, and they have co-authored that and they helped us write that, and they would be, they get equal authorship credit with us on that abstract. And if we present, we would love to try and find some way for them to be there and help us present this work. And they're not patients of the service, because I think that there's difficulties with power dynamics there. Like if you're the doctor but then you've got the patient coming in, and I think that's hard because they may not be as honest. So these are patients who know that they can just be honest with us and to say to us what they think, who have had a similar experience. And they actually, so they were volunteered from patient support organisations, PMR GCA Scotland and PMR GCA UK. And so they kind of knew what they were signing up for when they started with us. And they're very, they're fantastic at just challenging our assumptions and we would hope that any product, that anything we produce in terms of disseminating back to locally with within our department, and as we get and helping us evaluate whether things are working or not, but then also disseminating the project afterwards when we come to the end. We really want to involve them as as equals really in that process, because this is as much theirs as ours. It's really important, I think, to make sure that patients are part of the improvement team wherever possible, but just also being sensitive to if they are also a patient under the service at present, and particularly if you're already their doctor, that's a little bit difficult. So just trying to make sure that navigate that a little bit.
Thank you.
Okay, we're a tiny bit over time. Rob asked me to read his question. We don't have time for that right now, but if we have at the end of the call, even if it's just for the recording, I would love to bring this to the table. Sorry about that, Rob. We're tight on time. So let's go back to you, Sarah.
What we were going to do next actually was we were going to just have a little bit more Ellie, and Ellie was going to just discuss sort of our next steps that we're going to take in terms of moving from the sort of survey insights to selecting actions and some of the approaches, the possible methods for that, just to kind of look ahead a little bit. So is that all right, Ellie?
Yeah, I'll just show you kind of briefly the process that we would take, and then I think we're all really keen to open this out and hear your thoughts on this, what kind of experiences you have of doing this, and in maybe different ways as well. So I'll just share my screen again and take us back to this Miro. And we had actually been hoping to have completed this stage, but sadly due to sickness we weren't able to before this call. So maybe we'll be able to share some of the output from this with you all afterwards so that you get some kind of follow through. Yeah, okay, so the process of then working with the data in Sensemaker, we have this workshop, we're asking people to look at the patterns, look at the stories, really bring out some of the kind of key themes that are emerging. And then the next phase that we want to move into is this kind of sense of the insight to action. Okay, and how do we look to the stories for clues for where we might want to see change and at what different scales? So what we're going to be doing is we're going to be identifying from the analysis that we've done with this group, I would say maybe between 1 to 3 storybooks that will come from certain subsets of the data based around the questions that we've identified. So for example, we might look at the story in this top corner around understanding to give us some clues around what types or forms of education we might want to introduce, for example. And what we will then do with the group is we will ask them to read these storybooks one at a time. And we will ask them to quite simply put them into piles of stories that they feel as a group they want to see more of, and stories that they feel they want to see less of. Now, this is quite interesting depending on the stories you get back. If you have a very polarized data set, it's fairly obvious. Sometimes there can be a lot of discussion over one particular story if it's a little bit more nuanced. So very simply, we'll be asking them to put them into piles. If we were doing a workshop with lots of different participants across lots of different roles, what we might also be doing at this stage is to really kind of maximize that role diversity in our groupings. So just to be really crude, we might have a group of healthcare professionals over here looking at the same storybook to people with experience over here, to give one example. So when they start to do their story piles, we then are going to ask them to start pulling out some key themes from the stories. Okay. So once they go through this process, we're then going to ask them to think specifically about the stories that they've been reading and the themes that they've been identifying, and to come up in their groups with some ideas for interventions. And this, I think, is kind of fairly typical. We're asking them to think across 2 different scales. So what are the very small things that you could do as an individual or with a small group of people, maybe this week, this month, something that would make a difference? And sometimes we actually build that question itself into a Sensemaker collector so that we can get more voices in this process. And, what kinds of actions could be taken if you had no limits on time or resource? So really easy to understand questions for kind of anyone involved. We will then come together as a whole group and get people to share their ideas. And as a whole group, we'll do some plotting around effort and reward of the ideas. And then we'll get people to go through a kind of voting. Now this is the kind of simplistic format where we've got a really large data set and again, really kind of diverse stakeholders. So for example, a piece where we were working with adolescent girls on drivers for child and early forced marriage. We might have a very specific workshop with the adolescent girls and then feed their ideas for interventions into policy level stakeholders and say, well, how might you make this happen? So there's a few different ways, again, that we can kind of configure this based on who needs to be in the room. But at a very high level, those are our kind of next steps. Sarah, is there anything else that you want to add to that before we hear people's thoughts and other suggestions for this too?
I'd just love to hear a few more thoughts from the group because we only have a little bit of time left. So thank you. That's really great.
Thanks.
So same as before. Well, it didn't work before, but if you folks could use the raise hand button, it really, really helps. Go for it, Anna.
Thanks both for an amazing presentation. It's great to see it. And as somebody that's a visual thinker, I love the patterns and how quickly you can see things. So it's brilliant. I guess the one thing that it struck me is that you might have to have quite a confident person to be able to answer those kind of questions and to interact with the platform. So I wondered, kind of how do you cope with that and how do you make reasonable adjustments so that the platform itself doesn't end up skewing your data or biasing it?
Ellie, do you want to take that one?
Shall I start that one? Yeah. It's such an important consideration. And this is where a kind of testing phase really, really comes into play. Particularly if you maybe haven't been able to go down a co-design process, the idea of abstracting the core concepts into that framework, we then need to make the language accessible for different audiences. So, we'll go through quite a strict testing process where we're asking people to take part by actually going through it and sharing, and then we'll have conversations with them to get their explicit feedback on that. And quite often we will make adjustments, especially to the language there. And I think also I did to kind of draw on, there was a comment around the tech accessibility as well. That was actually a challenge that we came up on this, wasn't it, Sarah, with some of the participants, particularly when they were maybe using an app or a phone to take part, because the finger dragging and dropping is quite different to a cursor. So there are a few considerations to take a few things to take into consideration there. And some of them we're still working on the software and around. Sarah, is there anything else to add from you on that?
No, I agree. I think it's always a surprise that it was like some people saying, oh, I couldn't do it on my iPad, and someone else going, oh, I could do it on my iPad, and you wondered if it was different browsers or whatever it was. But with this, because they are people interacting from afar, they're via online communities, then it's quite hard to reach out and give them the tech support because you don't know who they are, because they're just they're anonymous. It's a totally anonymous survey, and it had to be totally anonymous because of information governance and data protection, all that kind of thing. And so there will have been some kind of self-selection, and some people who just do not like the internet will not have engaged, and that is a limitation of this. There are ways around it using face-to-face support groups run by the charity and sort of collecting stories that way, but we did not have time or resources for that. In an ideal world would have done that.
Great, thank you both.
Grand. I'm actually going to read Rob's question he asked me to read before, which is curious to hear how the measurement scale of certainty versus risk is incorporated into the interpretation or classification of the stories.
So I threw a red herring in there because that's actually from a completely different capture, just to give you a sense of some of the ways that we could design it. That was actually in the context of collecting leaders with the move to ICS. So there would have been a very different story prompt to that. Rob, if you want to follow up with me on that particular piece, I'll share my email and I'm really happy to share a bit more on it. But as it was for a completely different project, I'll give you my email and we can follow up. Thanks, Rob.
Gwen, you want to go?
Yeah, hi, thank you. I've really enjoyed the webinar today, and really wanted to just sort of say hello. And I'm in Leeds too, and Sarah, I'd love to sort of get in touch with you after this. But I suppose what I, as a clinician, I really care about shared decision making with my patients, and I feel that there is this professional responsibility to sort of share my concerns with the patients, whilst valuing what the patient concerns are. And obviously this is all is what we do as GPs, and takes time and relationship to do this. And what I wanted to say was it's great to see how the different perspectives of the different role groups are illustrated through using Sensemaker. And I think it would be, I think it's amazing to be able to sort of challenge people's perceptions, and a useful tool for reframing to sort of move things forward in sort of service redesign and making change. So, but my question, or what I am interested in finding out more about, is how you will go on in the future to balance that patient experience and patient concern and family concern with what the professional's concerned about, because it's that ethical duty that we have to also meet as well. So yeah, really looking forward to see what you do.
And I think you're absolutely right, and it's important that, you know, the clinician brings what they need to bring to the consultation, and the patient brings what they need to bring to the consultation. And I guess what we want to do, if we're going to educate patients, we want to give them the tools that they need to play their part in that interaction, and that includes listening to their doctor and developing a shared language, and making sure that we have that connection, that we can communicate and they can hear us as well as speak with us. And I think there's also a thing about, they do have to be able to kind of get what they have to tell you off their chest, and then they listen to you as well. So I think the listening and the that two-way communication, if it can flow both ways, then that kind of helps. So and I think there is a bit of a power differential, particularly with older patients, and they're often like, oh well, I'm just going to hear what the doctor has to say. But you do have to adapt it. So there are patients who are not listening, or they're not taking things on one end of the scale, and the patients who don't really tell you what they're worried about, and they don't tell you that they're not sleeping at night or things like that because they don't think that it's relevant, or they don't tell you about mental health problems because they don't think you're a mental health professional, and they don't disclose that, and then you kind of don't see why you're not moving forward. So that it is so complex, and it's all about that clinical skills of the doctor-patient interaction, isn't it? And how any education or intervention that we do has to kind of support that and not compromise that, doesn't it? It can't destroy their faith in what the doctor is saying. It has to kind of almost, because I think a lot of these patients, because they've not been able to contact either secondary care or primary care, I think they've had challenges with both, particularly secondary care with our inquiry line. So they kind of turn away from medical, and they kind of dismiss it, and they don't listen at all. And that's as much of a problem. And it's kind of post-pandemic kind of restoring their faith that we do listen, and we're there to listen to them, and we have to kind of reassure them of that before we can just start telling them, but look, you do have to take your weekly alendronic acid once a week. There has to be that kind of restoration, I think, in a way, for some of them. But it does depend on the patient, doesn't it? And you need to, somewhere in that consultation as a medic, you need to get your point across about what the key things that they need to take away from the consultation are. Yeah. A little bit to answer your question.
My method was really unpopular, but if anybody has extra comments or questions, this is the time. Well, perhaps we've reached the end of this call then. Thank you so much, Sarah and Ellie, for sharing all that knowledge. This is the last block we had. scheduled, or do we have? Yeah. Okay, grand. Yeah, that was lovely, and such an incredible resource for us to have in video for whoever wants to check it out later. Yeah, thanks very much. And thanks everybody who showed up in the middle of the day. And we're very happy to have you here every time.